Next paper is a global surgery paper that comes from UC San Francisco, Kids OR in Edinburgh, and National Hospital in Abuja, Nigeria, and will be presented by Dr. Ruth Laverde, Impact of New Dedicated Pediatric Operating Rooms on Surgical Volume in Africa, Evidence from Nigeria.
Hi, I'm Ruth Laverde. I'm a fourth-year medical student at UCSF. Thank you for the opportunity to present our collaborative work with National Hospital in Abuja and Kids OR. We have no disclosures. There's a large unmet children's surgical need in low and middle income countries. This study examines the impact of installing dedicated pediatric operating rooms on surgical volume in a public hospital in Abuja, Nigeria. About 96.3 million children reside in Nigeria. They comprise 54% of the population, and only about 13% reside within 2 hours of a facility with a pediatric surgeon. This particular site has 3 pediatric surgeons and serves an immediate population of about 1 million children less than 15 years old. It also receives referrals from neighboring states and other tertiary institutions. Kids OR is a non-governmental organization whose mission is to provide dedicated, specialized facilities and equipment for children's surgery in low-resource settings. To date, Kids OR has installed 50 ORs and aims to install 120 ORs in Africa by 2030. On August 2019, they installed 2 pediatric ORs in the National Hospital of Abuja. You can see an example of this OR on the right of the screen. After IRB approval from both UCSF and the National Hospital of Abuja, the changes in volume were assessed from July 2018 to September 2021, using interrupted time series of a prospective data collection tool that was created in partnership with local surgeons. Data from April to June 2020 were removed due to COVID-related lockdowns. Our results showed an immediate increase in surgical volume by 13 cases in the month of the OR installation, the majority being elective surgery cases. This graph shows the volume by elective surgeries in black and emergent surgeries in white. As you may see on the left side of the graph, the mortality of the monthly surgical volume for elective surgeries prior to the installation did not exceed more than 20 cases per month. And the month of installation, we observed an immediate increase of 11 cases. You may notice the emergency surgery volume did not change throughout the study period. We also found a significant difference between pre- and post-elective volume trends, denoted here by red. Post-installation volume of elective surgeries increased by 1 case per month following the installation. And with this increase in volume, we then asked what type of patients are undergoing surgery, and most importantly, what did mortality look like? We sought to answer if this increase in volume were of higher risk patients by using ASA class as a proxy for surgical risk. As you can see on the graph, there was a significant increase in cases ASA class greater than 2 following the installation. This increase in ASA class 3 and 4 paralleled the increase in neonatal cases depicted on this graph. It increased by 9 cases post-installation, and as you can see, there was a significant difference between pre- and post-installation case volume trends. When looking at overall mortality for all cases and between the study period, we found no differences. When cases were yet again stratified by ASA class, we found mortality significantly decreased within ASA class 3 and 4, which was significantly made up of elective cases. On further ITSA mortality of the recorded elective cases, there remained no difference in mortality pre- and post-installation. Within the study period, the monthly mortality rate was approximately 2%. In conclusion, there was a significant change in surgical volume after the OR installation, primarily composed of elective operations. This is supported by the increase in higher risk cases composed of neonates and patients with ASA class greater than 2. And despite a significant increase in volume and higher ASA class, there was no significant change in mortality, reflecting an increased capacity to address surgical backlogs and/or perform more specialized surgeries. This study supports the installation of surgical infrastructure to strengthen capacity without increasing postoperative mortality. I'd like to thank our senior authors, Dr. Ahmed from the National Hospital of Abuja and Dr. Osgood from UCSF, as well as the local team and our wonderful data collector, Nancy, whose work is invaluable to our project. Thank you for your attention, and I will take questions now.
Thank you.
Good morning. I'm Tamara Fitzgerald from Durham. Congratulations on a really great study. I just want to highlight what an important effort this is by Kids OR and other people participating in global surgery. I was just wondering if you guys have plans to look at any of the financial implications that there is of opening an OR.
Thank you for that question. Yes, so our group is also working on a cost-effective analysis to see what the economic impact will be of installing these dedicated operating rooms in multiple sites.
So I have a question for you. Maybe you could tell the audience in a very short segment, what does Kids OR ask the partner institution to commit to in order to get the Kids OR? And my second question is, in our environments, it's about staffing. I mean, the presence of the OR is not the rate-limiting step. So when a Kids OR is established, is there any allotment of staff that comes with it? Is there any support for staffing?
Thank you. That's a very important question. So the first part of the question is, how does a hospital kind of apply to obtain an operating room? Initially, Kids OR accepted applications, but most recently they partnered with the Ministry of Health, the local Ministry of Health, to identify which local sites are in need of operating equipment. And then I think the second part of the question was about staffing, and Kids OR does commit to paying salary for a trainee, but does not pay a house staff salary. And on top of that, the equipment that is provided is specialized, both the specialized OR equipment as well as surgical tools such as specialized for children's surgery, as well as consumables. So that has the consumables is just like the starting period to get the OR running, and they commit to maintaining all the equipment for its lifetime.
Thank you.
David Rothstein from Seattle. There is certainly a halo effect of having these beautiful ORs constructed, but there are probably components that are relevant to decreasing mortality and increasing capacity. Do you know, pre and post addition of ORs, what were the increased, for example, anesthesia monitoring devices? Was there oxygen supply as opposed to concentrators? You mentioned some of the consumables. Was there a difference in what was available to the physicians in Abuja?
Let me make sure I understand the question. So it's what type of equipment was available before and what type of equipment was available after? Is that correct?
Right, very specifically, did they increase pulse ox availability or oxygen delivery? Were those things that weren't there before Kids OR installed that specific module or not?
I am not 100% sure the answer to that question. My understanding is that they do provide anesthesia equipment, and these were brand new operating rooms. They didn't remodel, so I assume that if it came with the package operating room, then they would be provided new equipment.
Thank you. We actually have some of our colleagues from Abuja in the meeting here today, and I just want to welcome them. It's wonderful to have you here from Nigeria. Thank you so much.
Thank you.